with our conflicts of interest and declarations of interest. Anything new or pertinent to today's agenda? I'm not seeing any hands come in, Nick.
Yeah, Priya, can I just flag there are a couple of items which relate to mental health, which obviously also relate to my national role as Priority Programme Director for Mental Health, particularly the out-of-area placement update.
Thank you very much, Nick.
Yes.
Minutes of the board meeting held on the 20th of May. They have comments or approval. Thank you very much. And so we can move to our first item, which is mental health in schools team. And I'm going to ask Sarah Bellas, our Chief Nursing Officer, to introduce the item. And welcome to Yanni Chokalingam and Sophie Graham from the East Berkshire Mental Health and Schools team, who will be leading our presentation and will be here for questions as well. Thank you very much. Over to you, Sarah.
Thank you, Priya. I wanted to bring this team here today because I was really impressed when I went to meet this team a couple of months ago. It was a step change in how I've experienced clinicians, their enthusiasm, their positivity. In the meeting, they also had 2 representatives from schools who were equally positive, and that you could see the relationship between health and education and how it was impacting in a really positive way our young people. So I will leave them to do the rest. Thank you.
Hi, Sarah. I'm having real internet problem. My Teams, I've had to relaunch it, so apologies. Pete Saunders is going to be presenting on my behalf, hoping he has better connection than I do.
Pete's nodding, so should we go to Pete?
I think you might need to be unmuted, yeah.
There we go. Thank you, everybody. Thank you for the opportunity to speak today, and thank you for Sarah for the introduction. It's nice to notice that how well we are doing because we are passionate about what we do, and hopefully we can share some of that passion and enthusiasm with everybody here on the board today. So we are the CAMHS Getting Help team and mental health support team from Bracknell Forest. We'll give you a bit of an overview about the journey that we've been on, touch on a little bit of what we've been able to do, who the team is, the sort of interventions that we do, and importantly how we've been able to make those really effective working relationships across the different departments between Department of Education and Department of Health. So I believe I need somebody to move the slides for me. So yeah, please move on to the next slide, whoever is in charge. So this is our team. We're very fortunate that we have Alice in our team, who is a budding photographer, to make photos of us and make us all look probably a little bit nicer than we do in person. Or maybe I'm just speaking for myself in that part. Everyone else is glamorous, but just to give you a sight of the team that we have here. All of these guys are going out connecting with the 30 out of our 36 schools here in Bracknell Forest. We are putting these photos up in each of our schools because that's part of that relationship building and letting our school communities know who we are when we're on site as well. So the children, the parents, the staff, they all know that we're part and embedded within the school communities as well. Next slide, please. So just the core MHST priorities at a glance, this is all based within the green paper, the LTP and the Thrive framework, and within the slide deck, there's links to all of those if you wanted to read a little bit more about those. Essentially, effective early intervention in an MHST context needs to intervene early. We do that by offering assessments within 2.5 weeks and offering early intervention treatments within 3 to 4 weeks post-referral. We need to be fully integrated with schools, and how we do that is having regular school consultations. So with higher populations in secondary schools, we see them every 3 to 4 weeks to discuss pupils of concern. And then we also meet with primary schools once a half term, approximately every 4 to 6 weeks, to think about what the needs are of those particular students. But we also regularly have appointments with them to think about their whole school approach. An effective MHST early intervention service delivers evidence-based intervention. So these are interventions that are where we have the best available research or evidence to suggest that they work, and stick to those things, rather than thinking of things that might be influenced by things that are less evidenced. It has to promote school well-being, focus on vulnerable groups, and what we do, crucially, one of the things that our colleagues from schools that came to our meeting that Sarah was at highlighted how we've been able to help them navigate the system, how to best access CAMS, and having that one pathway into our service. And everything ultimately needs to be co-produced. We need to create those feedback loops with schools to get their views on what they think their schools need, because they know their community better than other people, but we help them maybe reflect and understand the wider picture from that as well, to help think about how they can maybe measure some of the impacts and some of the approaches that they're taking on board as well. Next slide, please. So the journey is a storied one. The 5-year forward gave us funding for the Getting Help team, where we were integrated with the local authority in Bracknell Forest. We created referral pathways, which linked in with the Early Help Hub, so that we could have a whole family and child and young person view of need. We quickly established a multi-agency meeting on Monday mornings to discuss referrals that we thought maybe had a mental health element into it. This then developed with the additional funding that came through in 2020 with the waves of MHST funding. Of course, we're aiming for the 100% coverage by 2029, but we were fortunate enough to have one of the earlier waves in 5s and 6. We were allocated a cluster of schools covering 8,000 pupils, which then quickly increased to 12,000 based on some of the schools, like King's Academy, Binfield, having a fair few only a couple year groups in their school, and expanding as part of that. We did things, we took on a few schools to begin with, helped to kind of establish pathways to learn how best to work and liaise with schools, then rolled out fully. As part of that, we try to then provide networking opportunities for mental health leads to support the mental health lead training, and sharing good practice by creating the mental health leads forum. Then in 2025, we received further funding for MHST2, which enabled us to get that coverage of 30 out of 36 schools. We engaged with some host schools to begin with in end of 2025, but now from January 26, we've got full coverage and regularly engaged with all of those schools, and we are regularly seeing referrals from every site, including special schools, secondaries, both primary and secondary. Throughout this, we have been a hub of training, and I've been very, very fortunate to train some really excellent clinicians. Some of them are here with me today that have joined our service, have been trained and led and helped us develop the service from their previous experience that they brought with us. Some who have worked in schools previously, have worked elsewhere, that have given us fresh perspectives. And I think that's one of the strengths of our team, is that we always have new perspectives coming in by often offering training contracts as part of our service. So yeah, constantly expanded to meet the local demands. We've been able to keep waitlist low. It's been nice to have the narrative of a CAM service that we're able to access, be accessible quickly for our local community, and change the narrative around CAM somewhat. Next slide, please. So this just gives you an idea of how the MHST2 came on board. We sent out expressions of interest. So we identified 4 host schools. We reviewed the processes that they had internally, and then set things up. The next slide, please. So the MHST really is one of those services that kind of really works in an interagency way. So because we had the benefits of the Getting Help team, we're integrated with the Early Help Hub and the local authority in social care, including youth workers. And then the MHST gives us that insight into the school community. So their SENCOs, SEN teams, pastoral teams. We also, as part of a scoping exercise, really identified, and Peter Swallows, the MP, was in agreement with us that we've got a very strong VCSE population within Bracknell Forest, such as Youth Line Counselling Service, Couth Online, mental health services and things like that, as well as the neurodiversity services and parents and special children and GEMS for Health. So we take particular effort to make sure that we're liaising regularly with them so that they understand our remit, we understand theirs, and then hopefully we don't have a little bit of bouncing between those sorts of services. But when referrals come into any of those options. Next slide, please. So to give you a bit of an idea about the impact that the MHST can have, here is the numbers of referral that came from Sandhurst School, which was previously under the Getting Help team and didn't have an MHST input. And on the right, what you can see is that once we've been able to get in and start helping schools understand mental health need and when mental health intervention can be useful, we saw a tenfold, I think it's 5 or 6 time increase in referral numbers for that population, further demonstrating how actually if you create awareness, you help schools have that protected time to reflect upon about pupils' needs and what they might need, to help them start co-formulating and understanding mental health and upskilling them. We then have more referrals coming in and we can intervene early. I will say quite confidently that a lot of these pupils will, without MHST input, are likely to deteriorate to the point that they become a little bit more known within the school, and then the intervention that's available to them might actually be higher up the hierarchy, if you see what I mean. So it's a true testament that the MHST gets in quickly, helps the school understand what to look for in terms of early intervention, and gets the referral in quick. Next slide, please. So just to demonstrate, we're aiming for the coverage. I think we've set the example and set the standards. We're very, very keen that actually, if given the funding to cover the rest of the schools, I think we would be able to benefit the whole Bracknell Forest community and continue to integrate and link up everybody. Next slide, please. This just to give you a bit of a taster of the typical needs, which is very reflective of kind of CAMHS in general. For those of you that are aware, we often see a higher rate of anxiety referrals because the presenting need itself is often to ask a health service to alleviate them of the anxiety, which can be very, very motivating in terms of referral seeking. CAMHS has always historically had high numbers of anxiety referrals, and with the rise in awareness of neurodiversity, a lot of stress symptoms also reported as anxiety, which often sees that being over referred comparatively to low mood, which should be higher in prevalence. What I will say is that we are picking up a variety of common mental health issues, and we are supporting schools. And I think the success story here, which is very subtle, is that the low mood referral rates are still quite high and representative of national prevalence rates. Low mood by its very nature is people are hopeless and low in motivation, aren't often seeking help. They aren't going to their teachers because they think that they can help. They're the opposite. So that we are getting these referrals in is, again, further testament to being able to get into schools, educating them about low mood, what that might look like in a classroom, to be able to then drive a referral and get early intervention. Next slide, please. So to give you an idea of the clinical offer, everybody has a 1-hour CBT informed evidence-based assessment that's been which is trained into our clinicians by the Reading University of Southampton. This is guided by NICE guidelines and individual formulation. They'll then move into 2 streams. Either it'll be a low intensity CBT intervention, so guided self-help around 6 to 8 sessions, focusing on how to manage worries, expose yourself to uncomfortable feelings through graded exposure, addressing behavioural difficulties through parent-led interventions, childhood anxiety through parent-led interventions. And those are the first-line interventions to offer when there's been no prior sort of like psychological need identified previously. We then also have the high intensity CBT offer, where we're able to support more complex interventions. So things like social anxiety, panic disorder, metaphobias, PTSD. These tend to be then an additional number of sessions afterwards to give more space to be able to engage in those things, because just a tad bit more complex. And then ultimately, we have a step care model within the MHST already, where we match the intervention to the need. And we regularly interface on a fortnightly basis with all of the other CAMS teams and specialist CAMS services on a fortnightly basis on a Friday, where then actually, if we feel that there's additional need and stepping up needs, we also take that forward with us as well. So what we're able to offer, and the narrative that needs to be for all of the schools, is that the MHSTs offer you that direct input into CAMS and mental health support. We're still seeing some coming via GPs, and families go there, but as is their right to access. But we offer no wrong door. So even if they go through those routes, they come to us, because actually then we can do a little bit of teaming up with the school to help them feel that they're an active participant in supporting a child's mental health and well-being, which actually, if you ask any teacher or staff member at a school, being an active part of somebody's recovery and from a mental health or a mental health difficulty can actually be really restorative and actually rewarding for a lot of staff as well. Yeah. Next slide, please. So I think I've got Caitlin on the call here, who is an EMHP, and I've unfortunately never been trained as a former EMHP, which give us a bit more insight into the whole school approach work. So just over to you, Caitlin.
Okay. Do let me know how we're getting on and when I need to be wrapped up by, if that's okay. I think we had about 15 minutes, wasn't it? So is that 2 minutes left?
Yes, please.
Thank you. So yes, so just a little bit more detail about when we're working with schools, what we're actually looking at, what we're sort of the framework that we're using to help ensure that the whole school community is being included and thought of in the approaches we're having. So yeah, so we've got 8 principles. So we do look at the sort of the actual ethos, the environment of the school, just how we're building up that culture so it's mentally healthy. We could be looking at the actual sort of curriculum as well, so more of those sort of PSHE lessons perhaps, and just incorporating that into the learning that they're having. So things such as the boards, the sort of display boards on walls. Often schools have now sort of started incorporating some of our sort of guided self-help interventions, sort of strategies, and having sort of worry trees on the wall, sort of a shared outlet for students to be able to share their worries, just as an example. Yeah, so yes, if we had more time, we would talk about these in a lot more detail, but it's just to ensure that we're encapsulating we're capturing the student voice, remembering the staff as well, because perhaps that can be sort of sometimes put to the bottom of their priority list when they're thinking so much about their students. They need to think about themselves as well, and parents, working with parents and carers is a very important thing too. I'm going to move along just in the interest of time, if that's okay. Can I have the next slide, please? Thank you. So Sophie was just going to have a little bit of a chat finally about the journey that a trainee would have as an EMHP if Sophie is on the call. I can't see everyone at the moment, but
I am on the call, Caitlin.
Hello, Sophie, just to finish up.
Yeah, again, in the interest of time, so I qualified in about February this year, so the training year is super fresh in my mind, but basically just to say that I think the EMHP role, so the role that I have, education mental health practitioners, brings in quite a diverse background. So we have ex-teachers, teaching assistants coming in, and also psychology graduates like myself coming into the role. So you get a huge range of perspectives, which I think, like Pete said, sort of adds to the ethos of the team as well. We're able to pull from a lot of different backgrounds and move things forward quite quickly. Problem solving is also really helped by that. But we all undergo sort of NHS funded training. So there's an undergraduate and a postgraduate diploma that you can do, which obviously means that there's no financial barrier to entry, which is, I guess, the main thing. Along with that, we are learning on the job, which just gives an entirely different and I think a really rich training journey. Great supervision from the team and from university intertwined. And I think, yeah, I guess that's mainly what I wanted to say, that ultimately a job is secured for you at the end of it. So there's a lot of job retention. And it's nationally consistent, so there's not a postcode lottery in terms of the level of training or how schools sort of, or I guess the extent of support they are given from EMHPs and mental health support teams. So it should be consistent throughout, which is I guess largely all I had to say.
Thank you, Sophie. And I was wondering if we could just skip 2 slides ahead. I believe it's 2 slides ahead, and we can just finish with, oh, maybe 3 slides ahead. We had some nice feedback just to finish on a positive note there as well. Sorry, we ran over a little bit. Thank you.
Thank you very much, all of you, and for being able to pull that together as well, and all speak with such depth and clarity. That's been really helpful. May I open it up? Oh, Hugh, come in first.
Thank you, Team Bracknell. Fantastic presentation. I'm sitting here in RBWM and wondering, what about my patients? And again, across the rest of the Thames Valley ICB. And Peter, you might not know what's happening, but you might do in through BHFT, and someone else might know what's going on across the rest of the team, because it's really fantastic and we all want it.
Yes, so RBWM, unfortunately, I'm about to move into a new role, which will give me coverage of all of East Berkshire, including RBWM. I'm aware that there are plans afoot for a second MHST to be able to come into RBWM in the near future. I believe that there's already an MHST and a Getting Help team in place in RBWM that are integrating with the Achieving for Children. I believe they meet on regularly on a Wednesday morning to co-triage in a similar kind of way to we do on a Monday morning, to think about sort of the whole family need within the population there. I think they work slightly differently because the local authorities work in slightly different ways, and they have slightly different processes. But I think are doing similar things to ourselves and great work. So if there's any linking up you'd like me to do, Hugh, with representatives from that team to help with building bridges, I'm in the business of making mental health more accessible for children and young people. I'll be more than happy to help you with that.
Thank you.
Nick?
Yeah, Pete, Caitlin, Sophie, firstly, that was fantastic. And the work you're doing is entirely in keeping with what we're trying to do as an ITB, which is focusing far more on prevention and delivering proactive care, particularly for children and young people, not least given the increase in prevalence of mild and moderate mental health conditions in that cohort. Just one sort of question for me. You focused on the importance of addressing people's needs rather than sort of moving down a diagnostic pathway. Do you use the International Classification of Functioning to assist in that? And is that something you may be considering rolling out if you're not using it already?
I've not had total familiarity of that myself. I would like to learn more and see how things, because I think we should always be in the realm of continuous professional development as professionals to stay up to date. I mean, I know from being a clinical tutor at Reading University is that research and evidence in universities and studying approaches and things often take on average like 17 years to get into standard clinical practice. So if you're giving us a heads up that that's something you can better, please share.
Yeah, I think it's been piloted in certain parts of the country, and as a school of thought, it's something we should be rolling out universally. So,
so it'd be good. I mean, we do use outcome measures, so the minimum data set of the RCADs, outcome rating scales and session rating scales. We also use disorder specific when we identified specific primary presenting issues. I guess the ORS gives us a functional impairment view, but yeah, if there's updates and things to be trialed out, I think we've got a great learning environment here where we're always keen to try new things out and try and give it a go. So yeah, please let me know if there's more to know.
Thank you.
Very interesting. Sarah, did you want to come in?
I just wanted to say I was really pleased to see again how enthusiastic this team are and the work that they're doing. It is impressive. So thank you guys. It was another great presentation.
Thank you, Sarah.
I think we've all echoed that. Yanni, Pete, Caitlin, Sophie, really helpful to hear firsthand from you of what you're concentrating on and what impact it's making. Fantastic to see the opportunity for this for all children across the Thames Valley. So to see
Priya,
how.
Safina's hand is
Safina's
up.
got a hand up. Priya, sorry.
Oh, I'm so sorry, Safina. Come on in. I couldn't
Not
see
to worry.
that.
Thank you. That was brilliant. Thank you, team. I think mine's linked to health inequalities. So just so you know, I'm Safina Nadeem, EDI Board Advisor, Equality, Diversity and Inclusion. And I was just thinking in terms of that health inequalities piece, we know there's kind of high risk categories, LGBTQ plus colleague people, young carers, asylum seekers. And I was wondering whether you pick up on that demographic and the specific kind of work that you're doing around that, and you're monitoring that as well. So I don't know who can answer that or.
I think I can, but I think Sophie and Caitlin, I think one or both of you are going to the Bracknell Pride event, aren't you? But
Yeah.
is that right?
Sophie,
Yes.
Sophie will be there.
And so that's not just to raise awareness that we do these things. We also have a and again, I guess maybe it's a Berkshire Healthcare approach, but it's certainly something in our service in the Getting Help East is that we have a diversity and inclusion project working group where we meet regularly on a monthly basis to think about how do we support underrepresented groups and protected characteristics within all of our clients. I mean, some of the things I can name off the top of my head that's come from that is that we've extended our 5P formulation framework to have a 6P to think about cultural identity and background when formulating about needs and what's maybe driving mental health need. We have continued to make further adaptations to interventions for neurodiversity, linking up with Reading University to be thinking about what is most likely to be impactful for neurodiverse mental health, because a lot of interventions designed or been trialed and researched on neurotypical young people. So there's less evidence-based and research there. I think we do like to promote ourselves in vulnerable communities. I know the guys over in the Slough team have done some works with going into mosques and other places where people tend to congregate to raise awareness and help increase referral rates there. We have an Eastern European population in Bracknell that we've been trying to integrate with, including the traveller population. So there's lots of work going in the background in a wider scope to enhance, because whilst you design a service for 80% of your population, there's always that 20% that you need to have that nuance and put a concerted effort in to make sure that there's equitable access to mental health for sure. Anything else, Sophie or Caitlin, that I've added?
I just wanted to add that both Caitlin and I are on we call it the participation group. So we meet monthly with members in RBWM, Slough as well, and sometimes with the West team as well, so Reading. We are currently actually onboarding a mental health ambassador program in Bracknell and Wokingham College. So in that sense, we're also trying to get student kind of voices, and hopefully they will influence the way that we do treatment, sort of write letters, communicate with young people and their families. We met with them yesterday. They have some really interesting and just, I mean, you know, they were so passionate about it. It was so lovely to see. So hopefully we're going to onboard a little bit more in September, but that's also, I guess, a way of making sure that we have our service users' voice kind of at the heart of it as well, and they're constantly influencing how we develop the service.
Yeah. Just highlighting those barriers from somebody who has accessed services or similar services is very rich. So yeah.
I think the next steps is, as we evolve as a service, is that we get even better at record keeping and seeing who is accessing our service, and importantly, who's not accessing our services, and using that to inform our approaches with engaging with the getting advice principles and the Thrive framework, because actually the barriers can be very complex and there's lots of intersectionality to consider, isn't there? So we need to always be having that in forefront of our mind when designing services and commissioning things for sure. Any other questions at all?
Well, thank you very much, everyone. That's been really helpful, and we look forward to a future update. It would be very good to hear more about what we can do across the whole of the Thames Valley. Thank you very much, everyone.
Thanks, everyone. Thank you.
Thank you.
I'm going to move us now to the first of the three parts of our agenda. This first part, our next four items, are our current operating context, and I'll hand first to our CEO, Nick Broughton. Thank you, Nick.
Priya, thank you, and good morning, everyone. There's quite a lot of content in the report, and I think that reflects quite how much is going on at the present time. I'm not proposing to go through it line by line. There's a couple of things I wanted to flag. Then I'm going to hand over to Ollie, if I may, who's going to provide a quick update in relation to the invoice backlog. I'm conscious Julian Ems can't be with us today, unfortunately, but just wanted to note that Berkshire Health Foundation Trust is one of 6 organisations that has been approved as an advanced foundation trust. That came into effect from the 1st of June. The report also references the recent publication of Baroness Amos' report into maternity and neonatal services across England, a really important report. You'll see that in response to this, an urgent 10-point plan has been developed by NHS England, and we are working very closely with system partners, particularly the trusts that provide maternity services, in relation to implementing that plan. And Sarah Bellers, our chief nurse, may want to say a little more in response to this in due course. And then finally, for me, in section 11 of the report, I referenced that yourself, Priya, and myself met with representatives from the regional team for an interview in relation to our annual assessment, and the letter and report following that meeting has now been received. In fact, we got it on Monday from David Radbourne in the regional team. It's been circulated to board members, and I would propose on the back of this conversation that we attach the report and letter to the minutes of this meeting, so it can be in the public domain. The report, I think, highlights that the disaggregation of the Frimley ICB in particular was one of the most complex changes undertaken by any ICB across the country, and the way the organisation has developed on the back of that, I think, is something that is recognised by the regional team. I also was pleased to read that the feedback the regional team received from a number of our health and wellbeing boards was generally positive. The report highlights a number of areas where the legacy ICBs were performing well, but also areas where there is room for improvement, not least in terms of cardiovascular disease prevention in what was the old Bob geography. So clearly we need to address those areas where there's room for improvement. But overall, I think it's a reasonably positive assessment, not just of the performance of Frimley and Bob ICBs last year, but also the work that's been undertaken, particularly over the last 8 months or so, beginning with clustering and then the formation of the new Thames Valley ICB as of the 1st of April. That is it from me. Can I hand over to Ollie, who's just going to say a bit about where we've got to in relation to addressing the invoice backlog.
Hi all, Ollie White, Director of System Financial Sustainability. Just covering for Rich this week. So in terms of the invoice backlog, that remains a significant focus for the finance team and the entire organisation. So we have made steady progress in reducing the backlog. We now have a grip of the new invoices coming in, and the backlog is coming down. So the total number of invoices we're approving is exceeding the number coming in. So that is a positive position to be in. The level of outstanding invoices is still too high though, and we continue to focus efforts on how do we clear the backlog, particularly the aged debt, because some of these invoices date back well over a year now, and some of them beyond. The challenge in that is that those are usually the more complicated cases that take more time and more of our senior resource to resolve. So that is it's definitely moving in the right direction, but it's not where we would want it to be in any respect. In terms of governance, we've put in a really strong program governance now. We have an executive escalation meeting every week. We have daily SIP reps and daily reviews. We've onboarded a significant number of additional invoice validators that are working through this, and more senior support has joined us over the last week to help really resolve the underlying process issues that we've identified, and we're hoping that over the next week this will move into the next phase of our program where we can start to use better automation to improve the efficiency of the work that we're doing. So overall position is still not good enough, but we are focused on how do we manage our suppliers. We've been communicating with them now weekly. We're shifting our external comms on the website to make it much clearer how to use the new financial ledger, which is causing some of the problems, and we're actively engaging with suppliers where they're identifying cash flow issues.
Ollie, thank you for that. Priya, I'm happy now to open up to questions from members of the wider board. Although I think Sam might want to in relation to invoices, because I know he met with members of the Care Association recently.
Yeah, thank you, Nick. Thank you, Ollie. Just on that final point with invoices, could I just put on the record for the minutes today our gratitude for the help and support we have received from the care associations in Oxfordshire, Buckinghamshire and across Berkshire as well. Not only have they been a tremendous ally and point of giving voice to their members, but have also been supporting us and ensuring that where suppliers are in financial distress, we have been able to make expedited payments and to relieve that situation. So we just wanted to publicly acknowledge that. Thank you.
Thanks, Sam.
Thank you. And let me open up to comments and questions in relation to the CEO report and any of those items. Thank you, Elena.
Two things. One, thank you for the updates. And Ollie, thanks for the update on the invoicing issue. Good to see that we are making progress, and particularly on the kind of new inflows of work that we're on top of that. Do we have a sense of trajectory? I mean, what are we communicating in terms of when we think we'll be on top of things and have a BAU situation that we're comfortable with? And then secondly, Nick, just a suggestion, and there was a lot of information in your report, which was great to see. I wonder, I've seen in other organisations a CEO report structured around strategic objectives and our kind of enabler, the 4 themes in our enablers. And I wonder if it's possible to move towards that, because from a non-exec perspective, it would help us make the links, I guess, between all the activity in a month, let's say, and how that's contributing towards our strategic intentions. Just a suggestion. Thank you.
Elena, let me take that away. Very sensible suggestion, but I'll hand back to Ollie in relation to the other point you made.
So thank you, Elena. In terms of trajectory, so priority focus is to ensure that we've paid suppliers that are identifying cash flow issues. So we will be ensuring that by the end of next week, we've made payments to all suppliers that have flagged those issues. So that's the kind of first stabilizing step that we ensure will happen. That will ensure that they've all been paid in the last kind of 30 days. In terms of the overall process and recovering and implementing the new routine that should resolve this problem going forward, the target is still the end of August to have this resolved, given the volumes involved.
Thank you.
Sorry, come in, Sajid.
Yeah, more a comment, Nick, but just for the benefit of the wider board, I attended a Oxford Thames Valley ICB Value Lab launch on the 2nd of July. I think this aligns with your reference to strategic commissioning capability. I think this is an important collaboration that we're engaging with one of our main academic institutions in the area. I know Hannah and the team have put a lot of effort into doing that. It was a very good turnout and some really impressive insights as to how we tackle the challenges of inequalities, access, and improving population outcomes. I know we also have other initiatives, population health units. I think it would be good just to kind of at some point just to do a bit of a primer around all these different collaborations we have, but I think they are force multipliers. But just Nick, just to reinforce that point you made in your note about the additional support coming from NHS England, but we are also investing locally.
Sajid, thank you for that. And as you know, one of the things we're very keen to do is to realise the potential of our wider system, particularly the academic organisations that exist within the system. So I think the Values Lab, as you've indicated, is a fantastic initiative, and many thanks to Hannah for leading that piece of work.
Thank you. Nick, is there anything else you want to draw our attention to before we move on to out of area replacements?
I don't think so, Priya. No, thank you.
Thank you. Okay, let's move then to Sarah Bella's Chief Nurse for out of area placements in mental health. Thank you, Sarah.
Thank you, Priya. This is a report just to provide assurance to the board on this important medium-term commitment in the NHS plan around eliminating unwarranted out of area placement. So an unwarranted out of area placement is a placement that doesn't meet the clinical need. It meets the convenience of the service because we haven't got enough provision locally, and that's the important thing. We won't always stop people being out of area, but we need to stop people being out of area that their clinical indication doesn't warrant it. So the plan is to eliminate it within 3 years, and the biggest issue locally for us is the availability of female PICU beds, the more intensive mental health beds. And so there is a plan to address that and increase the number of beds. We will be monitoring it over the time period to check that that's still the case and that it is females that are in the out of area placements and that the problem hasn't changed. And we will update the board as the progress happens. There is a reducing trajectory, as you can see, where there'll be from next year we'll be having no more than, let me just check the numbers so I don't get it wrong, 2 per quarter, and then eliminating to 0 by the end of the trajectory.
Thank you for the update, Sarah. And comment and questions? Come in, Nick.
Yeah, so this is really important, not least because the number of patients who are placed out of area gives us a sense of the overall quality of the mental health service that we are commissioning. And in keeping with that, it's now one of the 5 priority areas that NHS England will be monitoring for the rest of this calendar year. So I'm really pleased this is coming to the board today, and really pleased that we have made some positive progress in relation to reducing and hopefully eradicating inappropriate out of area placements.
Thank you both very much. And it's important that we, as the system board, keep in mind constantly the tie-in between the different issues that we are discussing as a board. So we've just heard about the work being done in schools around mental health, and that really is a driver for the prevention that we are trying to achieve. So very good to see those 2 things in close proximity. Thank you, Sarah. Let's move then to the SEND reforms update, and back to you, Sarah.
And Priya, you'll be pleased to know that we can continue the theme in this area because the SEND reforms focused on reducing the children needing an EHCP to get help and putting early help into schools to ensure that children get the help they need without having a plan at a time that they need it that makes sense. And it's the kind of the more physical health side of the mental health teams in schools, but a wider approach, including education, psychology, and other areas and things where we work together collaboratively. These reforms were announced in March, and the plans had to be in on the 19th of June. We had to deploy some additional resource to this area because we have 8 local authorities. We worked hard on the development of the plans and more explicitly on the development of the expert at hands model. This is in-school model of occupational therapy and speech and language therapy and educational psychologists and some other things. But from the health perspective, it's more the OT and the speech and language therapy. And the hope is it will have the similar effects to the mental health in schools teams that we saw in the earlier presentation. All of the reports came to Nick and I, which I read, and we've signed off. They were all of a really high standard, and we are awaiting the outcome.
Thank you very much. And I'll open to comments and questions. Zena, come in.
Yeah, thanks very much. And I think from all of our local authorities, thank you to the ICB for working through that really significant amount of work so quickly, because as the paper notes, it's a really significant financial consequence if we didn't get those plans in on time. This is therefore a slightly picky comment. And I know it's always very difficult to get governance structures and descriptions right, but the feel of the paper is very much, particularly supported by the governance structure, that the kind of ICB, it gives the appearance the ICB is in charge of this, rather than being clear about what the ICB's contribution really needs to be. And I raise it not just because I'm being picky, but also because I think it's really important that the ICB is very clear what aspects of the SEND reform it needs to have absolute, its contribution is absolutely to the forefront in, and it's not making sure that the whole system in each of our places works. So the governance diagram, for instance, looks like everything goes up to the ICB board, whereas of course most of the governance weight will rest locally in our places and in those local place-based partnerships. So I think if we can have some more clarity on what the ICB's role is, what it is absolutely crucial that this board gets right going forwards, that would be helpful.
Thank you very much. And I think that is a theme, isn't it? When systems work well, it's because there is clarity of who's leading what, with what purpose, with what accountability, so that we know and the public can be sure of where accountability lies. So thank you. Sarah?
And I think, just for assurance, Zena, I think we absolutely understand our accountability. I think this is the accountability of our aspects of it through to the ICB, not the totality of it. And I think it has been through partners, so we will take that back through the partners and make the accountability clearer.
Thank you, everyone. I will move us then to Sarah and Ollie, leading on quality, performance and finance. Thank you.
So we've got the finance report shared. This represents the month 2 position. As the paper notes, we have reprioritised a lot of resource within the finance team towards the invoice backlog. So for this month, we had made the decision to do a high level plan. It also builds on the plans that were recently submitted. So for this point, we've just reported everything on track. The other important part to note is this represents our new finance ledger, which went live on the 1st of April, and all of the new structures that are set up. So at the moment, we're still tracking to plan. We recognise the risks that were in that plan when we submitted it at the beginning of April, and focus remains on ensuring we've got the controls in place and our SIP plans are being progressed appropriately to deliver the overall position. That's all I was going to share on a finance perspective. Sarah, was there anything you needed to flag for quality?
I think the 2 areas in the quality report I wanted to flag was the complaints backlog, bringing the 2 ICBs together, and a historical backlog in the FOB side means that we are working to address this. It's not a standard that we would want for engaging with our population when they have something that they would like to share with us or a complaint, and therefore it's a really important thing for us to get right. We are in the middle of commissioning some work to help look at the processes and systems in order to have the most efficient and effective team as we move forwards. In addition to that, I think it's probably important to note some publications that are really important. So One that isn't in the report because it was only published yesterday is the quality strategy, and we will bring more about that at a future board meeting. But in the quality strategy, there is more of an emphasis on patient experience than there has been previously in the strategies that we've had before. And I think that's really important when we start thinking about the context of two other reports that I have acknowledged within the quality report, one being the publication of the CQC inspections at OUH and I've forgotten the name of the other hospital, it's in Banbury. Sorry.
Horton.
Horton, Sarah,
The
Horton.
Horton, that's right. Yes, you know when you just have a moment where it just goes completely from your mind, which the CQC inspection rated those services as good, and these were published at the similar time as the Baroness Amos report that was far less favourable about the experience of women using services through the OUH. I think there is validity in both of the reports, and that we can, it's helpful to see them side by side and learn from them, and clearly we want to support OUH to improve the experiences not only of the women but of the staff, because there is a heavy emphasis on the staff experience. As part of the response to Baroness Amos, they, as Nick earlier alluded to, appointed a 10-point plan that will need to be supporting the trust to work on. And a really important critical factor that they've identified in NHSE is the shared clinical leadership that is required for quality. This comes through in the quality strategy and also in the publication of the 10-point plan, where it's saying that the quality leadership shouldn't rest solely with the CNOs, that the CMOs need to be accountable and work in partnership. And certainly in the ICB, Lalitha and I work in partnership on these issues together. So that's just what I wanted to flag today. Thank you, Priya.
Thank you very much. Let me bring in Sajad first. Thank you.
Yeah, it's a question for Ollie around the strategic capital. I think this was discussed at the finance committee, the quality and finance committee, but just to kind of raise the point about how is this being allocated in terms of strategic outcomes and objectives of the ICB. So I know this is being invested in certain diagnostic centres or primary care. It will be helpful for the board to see how this capital is being aligned to that. And secondly, you know, the other perception, and I know Penny Dash has raised this, that a lot of these new diagnostic centres are being underutilised. Part of that reason, maybe it's transport. Part of that reason is, you know, where they're located. The other perception in Upton, in Slough, is that these are considered tier 2 services. So if you go into the hospital, you get kind of your Rolls Royce scan, and if you go to the high street, you're getting an inferior service. So part of this is an education concern. So I think what I would like to see is a sense of, you know, are we investing in the right places? But two, are we kind of maximising the value of the investment?
Thank you. Should we come back first to Ollie and then I'll bring Nick in?
Yep, so certainly. So our strategic capital programme went through a robust programme as part of setting the plans to be tested. I think, so as we get the new strategic commissioning committee set up, how those two dovetail together, I think is going to be really, really important. We know there's that lag of capital investment and then time to go in live. So how do we make sure we're looking forward over a multi-year process? So I think that needs to be something we pick up. Specifically on the CDCs, the way we commission CDCs is shifting. So this has been part of a national programme and it's moving more towards a cost and volume based service. The benefit for us is that we get better visibility of the activity that's going through and the impact that that's having on broader services. That then allows us to start testing those questions. Coming from the Frimley system, I know we've got the Slough CDC fully operational. FHFT are expecting to double the capacity they see going through that unit this year. So that needs to be something we monitor to make sure we're getting the impacts that we expect.
Thank you. Let me bring in Nick.
Sarah, in the report, you referenced the LEADER programme. I'm conscious that the annual LEADER report was published a couple of days ago. I know it's early days, we probably have time to sort of scrutinise that in the detail we'd like to, but where will we take the learning from that annual report as it relates to our system?
That's an emerging picture. So at the moment, we do have a LEADER group that looks at the LEADER reports and the responses, and as we move forward we'll have a learning into action group that will inform the commissioning side of things, that looks at the actions that come out for them and how they inform the strategic commissioning as we move forwards.
Fantastic. And the reason why I flagged this is obviously it relates to our key role addressing health inequalities, and the report this year highlights that people with learning disabilities are still dying 19 years earlier than the general population. So it does highlight there's a lot for us to do as an ICB, as indeed there is for the wider NHS. Thank you.
And I think, Nick, probably on that point, it's worth us emphasising that due to the challenges that Bob experienced over a while, there is a backlog on the historical Bob LEADER cases that we are working through at the moment, and we have not yet managed to complete the annual report for back till 2022, but there is a plan to complete that in the next couple of months.
Thank you, Sarah.
Thank you. Lalitha?
Thanks, Chair. Nick, I also just wanted to add that in any of the clinical programs that we map as an ICB, our ambition is to look at data specifically cut across people with learning disabilities so that we can actually understand the barriers to care to enable them to have, say, good hypertension control, good cancer screening rates, and so on. So that will then contribute to reduction in early mortality.
Thank you. I think that's a very good segue into our next two items, really around our commissioning role. First, we're going to have a neighbourhood health update, and I'll hand over to Sam Burrows. Thank you, Sam.
Morning, everybody. Thank you, Priya. Yeah, just a few words from me to frame this item, then very happy to open up for questions and discussion. But members of the board will recognise that our push to establish a neighbourhood healthcare delivery model is a major priority focus for us as an organisation and as a system partnership in the Thames Valley. It's a core plank of the 10-year health plan and one of the 3 shifts described in that health plan, alongside the move from analog to digital and from treatment to prevention. Also underpinning this is the move from hospital to neighbourhood, and this work is all around enabling us to make that a reality. It is an early priority for us as a new organisation to build a neighbourhood architecture which brings more health and care professionals and more services closer to people's homes so that our population can benefit from having to travel shorter distances and access the care they need when they need it. It's often not talked about in this way, but we should also regard it as a major intervention in our big push to eradicate health inequalities, given we know the barriers to access that exist for our deprived communities and populations, particularly when they have to travel greater distances to receive their care. Now, the board should note that we're not starting from a blank page in this space. There is at least a decade worth of really good work that's been happening in the Thames Valley geography, whether that's in the legacy Bob or legacy Frimley systems. That's all there for us to build on. But it has been happening in pockets. And our minimum ambition for this year is that by the time we go into 2027-28, we're in a position to have universal coverage of neighbourhood models in the Thames Valley, a clear sense of the needs of the population in each neighbourhood, and some credible service changes at that level, which allows us to address those needs. Now, you'll all be aware there's a national programme underpinning this government policy push. And a few weeks ago, we were delighted to host a visit by Dr. Claire Fuller and her team, who is the national lead for establishment of neighbourhood healthcare. We hosted that in Reading, and we were joined by representatives locally from all of our NHS organisations, our voluntary sector partners, ICB leads, and colleagues from the South East regional team of NHS England as well. In your paper bundle, you'll find a summary of the visit and the feedback that we received. There's some key messages in there as a board that we need to pay attention to. So we clearly have more work to do on establishing how accountability and decision making can shift to a more local or sub-ICB level. We've got further to go on confirming the exact shape and nature of our neighbourhood geography across the system, and confirming the plans for each of those and what our priorities are in each area. We've got more distance to travel, ensuring that we've got a robust interface between services which are provided by our brilliant GP practices, and then supporting patients as they step from primary care into secondary care services. And I think a theme which underpins a lot of this is actually around how do we get the maturity of our partnerships at a local level to a point where we can implement these new models of care and new ways of working with real trust and mutual confidence between each other that this is really going to work. And that's a big shift in terms of ways of working, culture, and OD support as well. So I'll finish by just flagging to the board that a really critical milestone for us this week is that we've now launched our specification of work for our Thames Valley Neighbourhood Development Programme. That's a cornerstone of the Thames Valley Innovation Fund, which is running this year for the first time, and it will really supercharge our efforts in all of the areas that I've just mentioned and that are described in more detail in the report. So nothing more for me to add at the moment, but as always, really happy to take questions that members of the board may have.
Thank you very much, Sam. Zena and then Ilona.
Yeah, thanks very much. Thanks, Sam. And you and I have discussed this this week, in fact. So one comment and one question. The comment is, and I'm not saying this because I'm suggesting you're doing this, but I just think we need to constantly guard against this programme or this movement being about neighbourhood health care rather than neighbourhood health, because they're slightly different things. The neighbourhood health care is a really important part of neighbourhood health, but it's not the only part, and we just need to be constantly vigilant that we are watching and driving forward both components. The question was really, so as you've highlighted in the report and as Claire's visit highlighted, some places are in different places to others, and so the question is, what can those of us who are lucky enough to be in systems that have managed to make more progress for all sorts of reasons, you know, kind of just the happy coincidence of singularity borders, for instance, what can we do to help pull everybody else forward? And in particular, I just wanted to just draw particularly on that PCN geographies, because I know, because I've done it in a different place, that getting PCN geographies to align is very difficult. It requires some quite robust conversations. So is there anything that we can do to help with that?
Thanks, Zena. So a couple of quick responses to that, if that's okay, and thank you for all of your support to us in this agenda as well. Firstly, you know that we share a common view on this, particularly around the definition of neighbourhoods and where we are focusing our efforts. And we really need to make sure that our health and well-being boards are the locus of the energy and the drive in this agenda that sits at a local level and is really sort of bottom up and place focused, and not something which is driven purely either by a Department of Health push or an ICB push in the Thames Valley, because we won't get this right if that's the approach that we take. So we absolutely are on the same page in that regard. And onto your second point, I'd absolutely like to commend Buckinghamshire for the progress it's made in this space. I think when we came together in Reading a few weeks ago, it was really obvious to everyone in the room how far forward Buckinghamshire are with the work that it's done and how much further it can go as well. So it's critical for all of us, I think, that this is not just about levelling up and holding those who are furthest ahead until the rest can catch up, but actually ensuring that those who are in a position of strength right now use that as a platform to go further and faster, and that being the basis of us spreading and scaling up what works for the rest of the Thames Valley as well. So all help and support appreciated in that endeavour.
Thank you very much. And just on that, I think there are areas where we are more fully formed in terms of neighbourhoods, that we can lean into those more challenging aspects that will really turn the dial on some things. So we've spoken about decommissioning frameworks and the role and the experience that local government has in that area, and also in variation of access and quality across all aspects of health, as well as health and care. And so doing that together through the neighbourhood lens is enormously helpful where relationships are strong and performance is strong as well. Ilona?
Thank you, Priya, and thanks, Sam, for the update. It's really great to see the progress here, the feedback from the Claire Fuller visit. Two reflections from me. One is from a non-exec perspective, and I look to my fellow non-execs to see if they're in a similar place. It would be great to help us gain a more detailed understanding of where this is working well, so we can kind of see why it's working well and how we can support that spreading across the region as a whole. And then secondly, I wholeheartedly support your the next steps that are outlined in your paper. I wonder if there's an additional one which is about using kind of program management discipline to hold ourselves to account for delivery here. I know there's the kind of helpful framework set out centrally for what we should be looking to achieve here at different levels of maturity. So I think there's quite a lot of information out there to help us do that, and you've talked about performance measures, etc. I guess I just want to be clear, what are the steps to reach your ultimate success measure in 2 years? Is it 2 years' time? Maybe it's not. Maybe it's less now. What are the steps we need to be taking to get us there? And can we put in place the mechanisms to get assurance that we're doing that? And if not, that then opens up conversations for making sure we've got resources in the right place, etc. So I just wanted to add that as what I would certainly consider a helpful additional step. Thank you.
Yeah, brilliant. Thank you, Ilona. Two fantastic questions, and hopefully I can give you some assurance on both. So firstly, I think we're really clear now what needs to be in place to have a minimum viable proposition for every neighbourhood inside the Thames Valley. And we know what those critical success factors look like. Some of that is a build on what's contained in the paper that you've got today. Some of it goes, I think, slightly further and beyond, but that's fine. And one of the products that I want to bring to the board after the summer holidays, once our development programme is established, is a heat map which shows across our geography where we have those success factors in place already and where we have deficiency, so that we understand as a board where each of our neighbourhoods is and what work needs to be done where to move everyone else forward. So it's absolutely on the work plan for the next month or so. The second part of your question, I think, around programme management discipline, again, completely agree, and this will be a core part of the approach as we get the development programme launched. So we need to have that really structured, shared approach that really ensures that everyone knows what we're shooting for and what it's going to take for us to get there. And then the only way you can do that is to have some rigor around that, which will require some program discipline. So again, please be assured that is the intention. And as we bring regular updates from the development program into this board and into health and wellbeing boards, I think it will be really clear the progress that we're making. So thank you. It's a really important part of what we're trying to do.
Thank you very much, and for that really rich conversation. Thank you. I'm going to move us then to the new hospital programme. Back to you, Sam.
Thank you very much. Now, we've got a handful of slides to share with the board today on this by way of presentation. So thank you, Sam, for popping those up on the screen. Could we go to the first one, please? And we'll just step you through it as we go with an eye on the time. So I think members of the board will be aware now, but in case not, the 16th of June marked a really major development point in the programme which intends to build a new hospital for the Frimley Park geography. And on the 16th of June, our colleagues in Frimley Health Foundation Trust announced their preferred site for the new hospital. Alongside that announcement, we collectively, jointly between the ICB and Frimley Health, launched a public staff and stakeholder engagement programme to hear the views of local people, of partners and of the workforce locally around what is being proposed, not just around the location that's being proposed for the new hospital, but also around the fundamental tenets of the model of care that sit underneath the delivery of the new hospital as well. I will remind the board that the ICB holds a statutory responsibility in this space, a duty to involve local people in major healthcare changes, and we've previously agreed a really robust engagement approach in partnership with the Trust to ensure that local people can have their voices heard around this programme. The purpose of bringing this paper to the board today is to set out details of the engagement that's been undertaken to date and to set out what the next steps are with this piece of work. Thank you, Sam. So to provide you some context around the local site, you can see on your map here, just to the bottom right-hand side, Pine Ridge Golf Club marked there. That is a golf course which is a small part of a much larger site owned by a charity called Frimley Fuel Allotments, and the Trust is proposing to purchase 55 acres of what is currently the back nine of the golf course as its preferred location for building a new hospital, which will deliver the full array of services currently provided at Frimley Park Hospital, which is around a mile down the road to the west from the preferred site. So hopefully that gives you some context of the geography involved with this proposal. Next slide, please, Sam. The engagement programme that's been launched is quite wide-ranging and robust. So far, we have held 6 in-person community events. The ICB has been represented at a senior level at all of those, alongside board-level colleagues from FHFT. That's either been myself, I've been to the last 3 in attendance as part of the presentational panel, or Ellie Davis, who is our Associate Director of Comms and leads our work on communications and engagement in this space. We've also held an online webinar that was yesterday to give people who couldn't join face-to-face the opportunity to hear more and ask questions, alongside 2 community pop-up events where we've been represented at other local major events that have been taking place during this period, such as the Armed Forces Day celebrations that took place in Rushmore Borough Council a few weekends ago. We've also held 5 staff pop-up events for the 14,000 staff who work for Frimley Health Foundation Trust, and we will be meeting with the Joint Health Overview and Scrutiny Committee that has been set up specifically to scrutinise this programme of work in 2 days' time when it meets on Friday. That will mark around the halfway point in this planned engagement programme, with a number of further events planned, and we'll continue to keep the board appraised of the discussions we have as we make our way through that. Next slide, please. In terms of the themes of what we've heard so far, now clearly we've not completed this first phase of engagement, but there are some really strong themes coming through. It's absolutely fair to say that a number of concerns have been raised, particularly by very local residents to the proposed site location. And those concerns range from a loss of potential green space. This site is currently situated on a golf course, which clearly by its very nature is open green space. There are concerns around road access and parking pressures. Again, that's not unusual for a major capital development such as this. Concern around the wider strain on infrastructure, and questions around how public transport will be able to serve the site that is being proposed. There have also been some questions raised around the site selection process, some concerns around the level of transparency around that process, and questions around the boundaries of the site and how the land will be used around it. Further information has been requested on the site selection process, and the Trust is taking a number of steps in response to that. So firstly, more information is being put out around how the decision was made around this site, trying to use some very plain English rationale so that it's accessible to all of our population, and to provide the evidence that's been used and what alternatives were considered. By the end of this week, a full site selection report will be released to the public, which sets out the 18 sites that were considered as a part of this selection process, the constraints which sit around all of them, and why this site was chosen as the only viable option for the proposed development of the new hospital. There have also been some initial responses made to practical impacts around transport, parking, construction, traffic, phasing, and the mitigations to those. But there is an awful lot more work to do in this space, and I've no doubt that will be picked up in more detail when a planning application is made and a full public consultation will be held during that process as well. From an ICB perspective, we're really keen to demonstrate that as an NHS, we're really listening to local people in this space. We're keeping a live Q&A updated, which shows the questions that are being raised and the answers provided. We will schedule additional community sessions so that more voices can be heard, and where commitments are being made to local people, we will ensure those are being tracked and regularly communicated with updates around those. And we also know this has an impact on our partners, perhaps those who are less visible or less cited on the programme than this organisation or Frimley Health FT. And working with our colleagues, particularly in Surrey and Sussex ICB and Hampshire Isle of Wight ICB, we are providing them with shared messaging, FAQs, and the information they need to answer the concerns of their local residents as well. Just to flag, the JOSC on Friday will be held in public as well. We're fully expecting members of the public to attend and ask additional questions, and we will use that as an opportunity to address concerns raised through that forum too. Next slide, please, Sam. Thank you. Some quick numbers for the board, I think, again, just to provide some assurance around reach and the level of engagement that this programme is reaching. So 4,500 social engagements week on week, 76,000 impressions on the website. And you can see in terms of the responses we've had to date, around a fifth have been negative, around a fifth have been positive, and 60% neutral. That's about, I think, what we would expect given people's interest in the programme at this current point in time. For a site which serves almost 500,000 people, we would expect that the vast majority of those people will actually be overwhelmingly positive around the proposal to build what I believe will be the best hospital in the country, if not one of the best hospitals in Europe, actually. Of course, there will be an impact on very local people, and it's important their concerns are heard and responded to. So we are seeing significant engagement on this, and we're really pleased with the response that we've had to date. Next slide, please, Sam. So just around in terms of what we've got coming up, another 20 pop-up stands planned, another almost 20 focus groups planned, working with our Health Watch colleagues with a particular focus on trying to get out to seldom heard communities. We really want to, again, use this as an opportunity to address the health inequalities issues we have in the local area. This is a great opportunity for us to hear from local people around some of those and build them into the programme. We've got more round tables, further focus groups. We're meeting with 6 schools in the local area to hear from them what their concerns or hopes may be around this programme. As you would expect, working with local broadcasters and local media to ensure that people have full understanding of the programme and how they can get involved. We're also expecting to communicate more intensively with the 22,000 homes that live closest to the new and existing hospitals over the summer, and that will provide further information and give them another opportunity to respond and work with us as we come out of the school summer holidays and into the September period and on from there. So there's a lot of information on this slide, but I think, again, it's just to provide the board with some confidence around the full range of activities that we are planning. Next one, please, Sam. Thank you. And then finally, and if there are members of the public who are with us today who have a particular interest in this programme and the new hospital build, all of the engagement materials, including the engagement booklets, which are physically available at the events, are available digitally on the website. The link is down here at the bottom of the slide in front of you on the screen. They're available both in standard form and in easy read information as well. And if you scan the QR code on the screen, then it will take you both to the web page, but also with a link to the engagement response portal as well. We're really keen to hear the views of people around this programme, and if there are members of the board today as well who would like to get involved, we'd love to hear from you too. So that's the end of my update on this particular item, Priya. I think we can probably take the slides down now. Thank you, Sam. And again, as always, happy to hear from members of the board and answer any questions you may have.
Thank you very much, Sam. I'll start with Sajad. Thank you.
Hey, Sam. In the light that this was also raised at Prime Minister's questions a couple of weeks ago, are we seeing any formal support being given by the national programme, Department of Health, NHS England, in terms of just that communication engagement with MPs and other kind of influential local leaders, so that, you know, it isn't just the ICB and the trust?
Yeah, great question. Thanks, Sajad. And can I take the opportunity, actually, whilst we're meeting today, to acknowledge the work that all 10 of the MPs who have constituents who use this hospital have undertaken alongside us on this programme. We have really strong relationships with all 10 of those politicians, and whilst there isn't always universal support, and the question that you referenced from Prime Minister's questions 2 weeks ago, I think shows there are concerns politically, locally, around what's being proposed. Actually, that's all really important and part of the process. And it's an opportunity for us to listen, to take stock, and to feed in to the work that we do. We are really well supported by the National New Hospitals Programme. Both Lance and I met with the national team on Friday alongside David Radbourne, who's the South East Regional Director for Strategy and Transformation, and we work really closely with them. They provide a really critical role in all of this. Firstly, to scrutinise the work that we're doing and act as a critical friend, so that it strengthens our local approach, but also to support us in our work, both with government and with other politicians, locally and nationally, to ensure that where people have got concerns or questions, they're really well responded to. So it's a real joint effort in that regard, Sajad, and we're grateful for the support that we get from the national team.
Thank you. And Nick?
Sam, firstly, thanks so much for that and the leadership you're providing in relation to this. And great that you highlighted the ICB's responsibilities in relation to the new hospital. I think it's just important to remind ourselves as to, you know, the fact that we actually do need a new hospital, not least because of the physical fabric of the existing building. It's not fit for purpose, real issues with reinforced aerated concrete, etc. And the fact that Frimley is part of the first wave of the new hospital programme, I think is something that we should be really pleased about. And as you really powerfully highlighted, Sam, you know, this hopefully will enable the system, the NHS, to build a state-of-the-art facility that's as good as anything in the country, if not better. So, you know, that has to be the sort of the driver behind something that we should always keep referring to. You know, the obvious considerations and concerns there always are with large capital programs of this kind, but the ultimate goal is one that we should not lose sight of.
Thanks, Nick. Completely agree. And this is genuinely a once in a lifetime opportunity for local people to make the most of a £2 billion investment in local infrastructure and improvements that won't just benefit the hospital, but the entire health and care economy for a population of, you know, 500 to 900,000 people who will benefit from this. So we have to make the most of it. And I'm really grateful for the support, not just from this board, but from FHFT and further beyond as well. It's something that we absolutely can't lose sight of. So thank you.
Thank you very much. And we will have regular updates at the board about the progress of the programme as well. Let's move then to our part of the agenda, which is around building our conditions for success. The first paper we will take is relating to the Lord Mann review and actions, and I'll hand over to Safina Nadeem, our EDI advisor. Thank you, Safina.
Thank you, Priya. I'm hoping people have had a chance to read the paper. Essentially, it was a previous Secretary of State that asked Lord Mann to do a review, and he was looking at the prevalence of anti-Semitism, anti-Muslim hatred and racism in the NHS. And I think the review itself kind of recommends a system-wide reset, backed by kind of leadership and accountability around anti-racism. So I'm just going to go through some of the recommendations, and then what I'll talk about is our approach so far. Before the board session, I did look at some data around from our staff survey, and what Lord Mann found was there was high levels of racism, anti-Semitism, and anti-Muslim hatred. And I'm looking at the last staff survey in 2025, that shows that 11% of Jewish staff and 16% of Muslim staff face discrimination from patients or the public. And 13% of both Jewish and Muslim staff reported it from staff. But what's really important to highlight in this is that for Jewish colleagues, this is increasing. So for Muslim colleagues, it kind of stayed the same, but for Jewish colleagues, it is increasing. So in terms of the report and the recommendations, there were 36 recommendations that Lord Mann recommended, and they had kind of 5 key themes. There's a real strong focus on accountability and leadership, which has kind of been different to previous work around anti-racism. So it has to be a core organisational priority for the board. And alongside that, some of the recommendations that every board member should have an anti-racism objective as part of their appraisal. And also there'll be a new tackling racism composite score as part of the NHS oversight framework as well. So that's kind of really new in terms of previous standards and frameworks. There's a focus on improving data around the workforce race equality standard, but also using that data and staff survey data to drive improvement. And again, boards having a really good understanding of what that is to help drive that improvement. And then the other areas were around making sure we have a culture for people to speak up. Again, the review found that lots of staff would not speak up about racism or report it. So there's something around making sure we have the right culture, and then creating that kind of psychologically safe space. Lots around training, mandatory training, e-learning, and in the recommendations as well. And I know NHS England is going to be starting putting together training, e-learning specifically around anti-Semitism and anti-Muslim hatred. So that'll be coming in. Following the publications, Jim Mackey and Dan Mortimer wrote to all the organisations and asked them to kind of adopt following actions that you'll see in there. So that was looking at signing up to NHS Race Observatory principles, implementing the Violence and Prevention Reduction Standard, and also kind of adopting the new government definition of anti-Muslim hostility. And then lots of things around making sure that we have the right training when it becomes available. Whilst before this, after this paper went out, we have seen the NHS standards that have come out as well, and they link. One of the NHS standards is going to be around addressing racism in the organisation, and again, that's going to be part of the NHS oversight framework. So just to quickly say that both legacy organisations, Bob and Frimley, we've done a lot of work around anti-racism. We already had anti-Semitism and anti-Muslim hatred definitions as part of our anti-racism work. And the plan is that we are going to be looking at both legacy organisations' work that we're doing. We've got an anti-racism framework that we're going to be benchmarking across, and making sure that we build all the recommendations into our approach going forward. Some things that information that we're waiting for from NHS England before we devise our action plan. So we wait for that to happen, but we are going to be carrying out some of the work that we're already doing around workshops, having dialogue. We've had interest from some communities to get involved in this work, particularly around anti-Semitism. So we'll be doing some staff engagement and some community engagement, but really want to get this right and making sure we've got the best approach to make sure that we are addressing racism, anti-Semitism, anti-Muslim hatred for our colleagues, but also understand impact on inequalities for our communities as well. So I'll stop there, Pri. I'm happy to take any questions or clarifications.
Thank you very much, Savina. Really helpful and clear. Comments and questions, please, members of the board. Caroline.
Thanks, and thanks, Safina, for the paper. I know we're going to catch up soon, but your paper just reminds me of, I guess, reflecting on the past. What is it I learned as a leader through our anti-racist framework, and I suppose challenging myself about seeing something come from a major review that you intuitively want to support, and then feeling concerned about an over-reliance on training and development. My learning through our work had been that psychologically safe environment where as leaders we explore this and connect with it, and the difference that makes as you confidently step into spaces to say, I'm not confident. How is it that I open up conversation? How is it that I as a leader accept my and understand my responsibility not to shy away from the difficult conversations? So I guess I'm holding on to and want to continue to reflect on that, support you, support us as an executive team, as a broader board about. It's obvious thing to say, don't treat this as a tick box exercise and great, we've got a plan that sort of meets the 36 recommendations and we've got this, we've got that. It's really challenging ourselves on what does it mean to be a leader that commits to anti-racism, and what does this piece of learning offer us, rather than the danger of falling into the trap of, don't worry, we've got some new mandated training and development coming down the line.
Can I respond to that, Priya, quickly? Yeah, I think you're absolutely spot on, and there is an over-reliance on training and development to develop people, and I think how we've done it previously is that dialogue and that human connection and understanding the impact of racism on people, which has, I think, led to the transformational change and culture change. So you're absolutely right, and there has been some criticism, I think, from Roger Klein as well, who said we shouldn't rely on e-learning to change culture. So totally agree with that. Thank you, Caroline.
Thank you. Tim and then Ilona.
Thanks, Priya, and thanks, Safina. It's a really good summary of the report and then some concrete action, so I appreciate that. And obviously hopefully it goes without saying that I fully support it. Just one sort of practical point. Obviously this year we haven't had the staff survey for all the reasons that we know. I think that was probably the right decision. With this particular lens, this particular focus though, how are we going to get a temperature check of how things are in this area as we stand, before we start this good work? Is there anything we can do in terms of a smaller survey or some sort of sampling? I don't know. I don't know if any thought's been given to that. I don't necessarily expect the definitive answer now, but just be interesting to know if we can put some thought toward it.
Yeah, I think in terms of the ICB, we didn't have the full staff survey, but in terms of our organisations, we've got quite a lot of intelligence. We have a lot of intelligence through our staff networks as well, so we'll use what we have, but kind of continue that dialogue, like that what we said earlier, in terms of making sure we really understand and get a good understanding of blockers, barriers, but also what is happening on the ground as well. And I'll let Caroline come in as well.
And just to support that, and we have signed up to the National Staff Survey that will roll out October. It'll be after Christmas. We'll get that data. But I guess I think we're sitting on a lot of data. I think we're sitting on a lot of observations and insights. And as I'm particularly keen, we draw from the networks. I'm just thinking about our organisation for the moment rather than the broader system. So balancing what's all the data, insights, observations we've got at our fingertips, how we engage with the networks, particularly as we sign up to and get the annual staff survey data running through again.
Thank you. Ilona.
Thanks, and thanks, Safina, for a really thoughtful report. That conversation there was just straying into the thing I wanted to raise, which was just getting clarity on our role as an ICB in terms of driving this agenda forward under the new framework for ICBs and as an employer, I guess, and then our role system-wide. My assumption had been the system-wide aspect comes more through how we would embed this type of concern in our strategic commissioning approach, but I just wanted to pause on that if we've got time, Priya, just to get a view from exec colleagues, and particularly to help me make sure I'm focusing on the right thing. So, you know, seeking assurance about how we as a board are tracking this, taking this forward, leading it through our own behaviours, etc., versus what our responsibilities are system-wide and how we drive anti-racism through our contracting and commissioning versus kind of system collaboration, etc. And I hope the question makes sense, but I just want to, if it's possible, get a bit more clarity on that. Thank you.
Very helpfully set out. Caroline?
Do you want me to jump in, Safina? You know, I'm passionate about this. I start from a place, I think we start from a place of we're system leaders. So yes, I focus on, of course, the people of the organisation and ensuring that the ICB particularly is a great place to work, feels like an anti-racist organisation and responds to that. But I guess our leadership roles as system leaders, as well as our contractual and strategic commissioning levers, I see the intersect between those things. So how do I lead? How do I influence? How do we ensure our teams feel that they can lead and influence, as well as pulling the strategic commissioning levers, contracting levers, and then as an ICB employer, role modelling what this means in practice.
That's really helpful. All I'd say in response is I think just drawing that out a little bit more. So I get a sense, looking back at the work we did in Frimley, for example, I felt I had quite a good grasp of what we were doing as an ICB for the ICB versus our system-wide role. I have slightly a less firm grasp of what that feels like in the new world, and I think we could quite rightly focus inwardly initially on this, and that would be a reasonable thing to do given the change, etc., that's underway. But thinking at some point how we maximise our influence through our commissioning role to support an anti-racist system feels like an important thing that I don't think is yet fully articulated here. And then if there are softer things we still want to continue with as a system leader, let's spell those out and make sure we genuinely have a role there that others support and welcome, as opposed to being seen to duplicate, trip each other up in this space. And that's not to undermine its significance. It's almost the opposite. It's to make sure we have the best impact we possibly can. Thank you.
Thank you. Sabina, did you want to come in?
I did. I think it's interesting, isn't it? Because there is something around the system individual leadership role, and again, I think the difference with this is there is some accountability, and it shouldn't be, should it? It shouldn't be that because there's accountability and there's oversight framework scoring, we should be doing this. I think for board, for us as leaders, it's understanding the benefits that this will bring in terms of achieving our strategic objectives around reducing inequalities. So there is something around individual leadership, but actually what are we role modelling and signalling out there to our providers around this to say, we're going to be role modelling and we're going to be leading this, but it's also a really big part of our commissioning in terms of EDI anti-racism as well. So yeah, totally agree, Lorna. Thank you.
Thank you. Sajad.
Yeah, I mean, just I think the other nuance to this is how this is actually monitored and tracked, because I think Lord Mann made a distinction between what you do at work and what you can do in your private life. So obviously, you know, it is a sensitive topic. Staff members, you know, have the right to have distinct views. Some may perceive those as, you know, potentially borderline. So the question is, what in determining policies and training and whatever, I think we have to make a clear distinction is what staff are allowed to do in the workplace versus what they can do on their weekends, what they can do on social media. I think it's a difficult topic. There are black and white, but there are also very grey areas. And I think we need to be kind of sensitive to that split between work and non-work, if that makes sense, Savina.
Yeah, it absolutely does, and I think that's why really important that when we do this work, we engage with colleagues and our communities. I think there is a distinction between work and home, but we've also got policies like our social media policy as well, so and values that we have to make sure we align with. So I think there has been some pushback from the BMA as well in this space, the British. So we are seeing conversations evolve. So, and that's why I didn't really want to rush into this. I really want to take our time and have the right conversations. And I think one of the recommendations is around the uniform policy that the NHS England are going to launch, and that is going to be about kind of what you can wear, political badges at work or lanyards. So there's going to be lots of kind of discourse and conversations, I think, going ahead.
Thank you, Sabina and Caroline, and thank you everyone for the discussion. I'm going to move us now to the Frimley Health NHS Foundation Trust delegation agreement, and over to you, Sam.
Thank you, Chair. So relatively quickly from me on this by way of introduction, the board will be aware that as part of changes to how ICBs are being configured, that we are planning to delegate a number of functions which are currently held by the ICB to Frimley Health Foundation Trust as a local partner. And that includes the delivery teams for all age continuing care and CHC, medicines optimization and prescribing, community equipment service, and also our primary care operations. And I'd just like to state for the record of this meeting, we are particularly grateful for the joint work we've been able to progress with our colleagues at Frimley Health Foundation Trust, which has been conducted incredibly professionally all the way along. We're now fully set for a planned transfer of and delegation of those functions ready for the 1st of September of this year. And it's important that the board notes and is aware the ICB will remain the accountable statutory body for the outcomes and performance of those functions. So it is critical that we have an agreed way of working with the trust, which allows us to continue to discharge our statutory accountabilities and provide this board with the assurance that it needs that we are doing so. To achieve this, we are proposing the establishment of a joint committee chaired by Nick as Chief Executive of the ICB and joined by a non-executive member of the ICB and a non-executive director from Frimley Health Foundation Trust. We'll use this joint committee to monitor performance, to oversee delivery, and to resolve risks and issues as and when they arise. It will report directly into this ICB board and to the board of FHFT, and both boards will ensure that these arrangements are working effectively for both organisations, for the teams who are working in these functions, and for the populations which we serve. So the purpose of bringing this paper to the board today is to seek approval for the establishment of these governance arrangements, but in particular, the joint committee which I've just described. Thank you.
Thank you very much, Sam. And let me open that up to comments and questions. This is an important delegation. It contains a number of key areas of work and impact beyond the numbers of individuals who will be transferring, and we want to have them transfer well. So it's a key area for us. Come in, Tim.
Thanks, Priya, and thanks, Sam, for the paper. It's just to reiterate, and we've spoken about this previously, Sam, but just for the public board, really, just to reiterate the importance of ensuring that the baselines in this transfer are clearly understood by both parties and, of course, the teams that are delivering this. I've got great confidence we can do a good job with our partners in Frimley because it's the same people who've worked closely together for a long time. So there's a good positive chance of continuity, but just want to get your reassurance for the public, really, that that final bit of work, which is very important to establish baselines, is in hand.
Yeah, absolutely. Thanks, Tim. It's a really important question. So now that we've reached the end of the first quarter of the year, I think we now have the information we need to get a really robust snapshot of performance, both in terms of operational delivery and financial performance of these functions, and they'll form the baseline in which we are monitoring, tracking delivery once this delegation takes effect. The Joint Committee will have this as a standing item in terms of how it constructs and uses its time, and will be reporting not only to the Joint Committee, but via summary back up to this board as well, to ensure that there is collective confidence we are delivering an improvement against the baseline position rather than even just maintaining it. So thanks, Tim. It's a really important point.
Yeah, absolutely. Nick?
Yeah, and just to flag that this is a key component of our change delivery programme, and the agreement that's before you today is on the back of extensive conversations with colleagues at Frimley Health Foundation Trust. And Sam, forgive me if you mentioned it, sorry, I might have had a mind blank, but did you flag that the Frimley Health their board has approved this?
Thanks, Nick. I should have said that. Yes, Frimley Health Board met 2 Fridays ago and have approved the delegation agreement and the request that's in front of this board today for the establishment of this joint committee. So seeking approval in kind so that we can now move forward with setting that up.
Excellent, thank you.
Thank you very much. If there are no other comments or questions, may I ask formally then for the board's approval for the establishment of the joint committee between the ICB and Frimley Health Foundation Trust. Thank you very much. And we've noted and support the delivery of the arrangements for the delegation. Thank you. Good. Let's move now to our board assurance framework and governance update. And over to you, Caroline. Thank you.
Thank you, Chair. Focusing on the board assurance framework, colleagues, hope you've had sufficient time to review the detail. We're seeking approval of the board assurance framework, given the detail that's now been built. Obviously, our board assurance framework enables us as a board to hold ourselves to account. We will be regularly reviewing it so that we have evidence that we've got the right controls in place, that we're mitigating the risks as we see them, principal risks as we see them, against our strategic objectives. We had previously developed as a board our strategic objectives. The development of that work in front of the board today is having codified now those strategic objectives and the principal risks. We've set out a set of risk appetite statements, and also given a first pass at where we see the gaps in assurance and the controls that we have in place. So wanted to make sure, as I say, as we became an ICB back in April, we've iterated this as a board, taken it through the executive team, and also brought together the risks as were for Bob and Frimley ICBs, consolidated those in the background, the executive work on those, and have worked in effect bottom up to support the identification of the principal risks as we as a board set out the strategic objectives going forward. So I get the main point here being that I'm expecting recognition of the strategic objectives, keen to get the board's view about the risk appetite statement, particularly having met in private in June. We signed off that risk appetite statement. The development below in the paper is the 7 principal risks in particular, and highlights how against our governance map the committees of the board, which of those committees will oversight those principal risks. That's set out in the paper, so I'm looking for any comments, but particularly to note not just the development of the BAF, but to approve this document in this state, knowing that the board will receive bi-monthly updates in public, so that we can assure ourselves that we are oversighting appropriately the risks associated with those strategic objectives, and ensure a proactive approach to delivery of those strategic objectives. Thank you, Priya.
Thank you very much, Caroline. Just before I open up to comments and questions, I've joined on a second device because I have a fire alarm going off in the background. So it's a mobile device in case I need to move. But I know that I will be able to rely on Sajad as our deputy to make this a seamless experience for everybody, but I might be on the move. Now, let me open up to comments and questions. Ilona, thank you.
Thank you, Caroline, and really good to see this at this stage of development early on in the life of Thames Valley ICB. So I'm really grateful for that. I'm conscious because we wanted to move at pace that we haven't had a chance to look at this at the Audit and Risk Audit Committee before it came here. So just for people to note, it hasn't been through that route, and I think ideally it would if we hadn't been keen just to get things pushed through. So a handful of comments from me. I guess I'm happy to sign this off as it stands, so we've got something to work on if that's the view of the collective here today. My suggestions are all in the spirit of, as this iterates, can we think about, let's put it that way. So the things I'd quite like us to think about are giving ourselves assurance that we've encapsulated what I would describe as our risk universe. So, for example, I see we've got something in there on complaints, which is a live issue that we've been talking about. So is the invoicing issue that actually at the moment doesn't instantly jump out at you here, which might be fine because of the way, it's a live issue, not a future risk. It's inherent in some of the higher level things here. So I just wanted a bit of assurance that we have really considered our risk universe in coming up with this list of principal risks, and that we haven't missed anything out. That's point one. Point two is, could we, in the headline descriptions, and I was just trying to look at a few other ICBs this morning and only managed to check a couple, but could we think about actually articulating the risk? So they're down as kind of themes, and I think it's usually helpful if you spell out what are you worried about here, because it just creates a bit of discipline in your thinking and how you then explore, well, have we got the controls in place? What are the mitigations, etc. So I personally would like to see the headline risks as risks, not themes. And then a couple of more specific points. I really welcomed the link, the kind of governance route. I think that's really good. And as chair of the audit committee, I was particularly pleased to see that. My question is just offline, Caroline. Can we just work up a way of providing the right assurance back up to the audit committee that those other bits of our governance system are doing what they need to for assurance on those principal risks? You'll remember we had an incident in a legacy organisation where we thought something was happening when it actually wasn't. So I want to avoid that going forward. And then a specific one on cyber. I see we've got that under the commissioning and population health subcommittee. I just wanted to check the rationale there, because on the face of it, it feels like a bit of an odd fit. Sajad, I don't know if you've been consulted on that, but I just wanted to make sure we were all happy with the rationale for that one, given it's been one of our top worries in recent times. Sorry, that's quite a long list. And Caroline, I'm happy just to park all of that and take it offline rather than get responses today if we're short on time. But a big thank you for getting us to this stage. It's good to see.
Caroline, should we bring in Tim and then?
Yep, I'll do it. Yeah, sure.
Yes. Yeah.
My thanks, Priya. Thanks, Caroline. Mine should be quite quick. I had picked exactly the same point as Ilona about the cyber risk. I wasn't quite sure why that committee, so question mark over that. And the second one, again, Ilona touched on it, and it flowed from our conversation yesterday, a non-exec conversation we had. The point around the complaints procedure. Is it actually a more generic heading than that? And it's actually something like, day-to-day operational effectiveness or something like that, because at the moment it's complaints and invoices, that probably will evolve over time, and we should constantly be on the lookout for operational effectiveness for our service users or something like that. And then as Alona said, we tease it out and it evolves with a bit more detail, and that's the part that might change. I'll just leave that again as a thought.
Thank you both. Priya, if you're happy. I'll pick up the cyber piece with Hannah offline in terms of rationale for docking there. I think I'll and also pick up with Alona offline that sort of stress testing how we provide assurance that the arrangements between committees are working such that the audit committee can be assured it's all happening in the other committees. How do we test that? The theme versus the risk. There's some detail in the additional the paper that sits behind it that expresses the risk in more detail. But again, I'll pick that up with Alona if you feel that's not sufficient. And Tim, I'm with you and Ned's in terms of this is exactly the conversation we've been having at execs about, okay, invoicing complaints, stabilise, assure the backlog, and then transform in terms of, and it's what does better processing re-engineering look like. The conversation we've also had at execs is go look at your risk registers. What's the next issue coming over the hill? So that operational effectiveness is absolutely a weekly, bi-weekly conversation we're having in execs about stabilise, but what are we worried about next in terms of operational effectiveness? But happy again to pick up that with non-exec colleagues offline.
Great, really helpful. And the cyber may have come out of the GPIT element rather than where it should sit in terms of audit. So that probably won't be quite an easy one to resolve. Sam, did you want to come in? Before I bring Sajid in? No? Okay, sorry, my mistake. Sajid, come in.
Yeah, I think the context I saw the cyber stuff in is the audit committee should manage all the risks. But where does, for example, digital strategy, cyber strategy sit in terms of the subcommittees? And I'm not necessarily thinking it's that one, but I don't think the audit committee is the right committee to deal with the strategy side of it. It's the right committee to deal with the controls and the risks. But which board committee is looking at AI, digital, the cyber strategy in terms of a proactive opportunity type thing? So I think we've got to kind of figure that out. I think that's where I would kind of see the two things operating in tandem. Alona, if that might help for context.
Yeah.
It wasn't a plea for it to fall to the audit committee, and actually just to nitpick, I don't think the audit committee manages the risks.
No.
The audit committee gains assurance that risks are being managed. So we would gain assurance across all of this going forward. I just wanted to make sure that we had the cyber risk, the kind of more detailed scrutiny falling in the right place, and maybe the point is there's no natural home for it and we need to just think about best fit.
I think the logic was that digital in its broadest sense, analytics and capability is a foundational element of our commissioning, not just objective, but it links to the Commissioning and Population Health Committee. That's the forum that is, in effect, the committee that is focused on that foundational capability in order to deliver a commissioning and population health strategy. We can look at it, happy to take it offline with Hannah in terms of what are we reporting through where and for what purpose.
Really helpful, and there may well be a separation of the strategy and then the oversight, because one of the things we do we've asked for clarity on is accountability and responsibility for different scales. So what is national, regional, ICB, organisational, etc. Because cyber is such an important underpinning for all of our work together. So that's really helpful. Could we take that and explore it more and be sure we don't lose the strategy side of it? Fantastic.
Thank you.
Any other comments or queries in relation to the BAF and governance? Was there anything more you wanted to say on governance, Caroline?
No, don't think so. We'll use the next board meetings either in seminar or in public to develop both the governance handbook map, function and decision map, etc., and keep the BAF a live focus for all of that.
Good. Okay. Thank you. So from that, we are as a board approving this final document with the caveat of the areas which will be developed before we next consider the BAF, and will go to audit before it comes back to board as well. So thank you very much. Good. Let's move then to our AAA reports. And we have audit, remuneration and people, commissioning and population health, quality finance performance. So should we start with audit? And everybody has the report, so I'll ask our chairs to guide us to those areas for discussion. Over to you, Ilona. Thank you.
Sorry to be slow coming off mute. To be honest, Priya, I mean, we've had two audit committees since the last public board, one in May and then in June, the key annual one, if you like, that was signing off legacy organisations. So Frimley and Bob ICB, annual reports and accounts, and head of internal audit positions for the 25-26 year. So it feels a bit out of date already, but and it's all documented there. So I just kind of want to say it's there. I'm happy to take any questions. I really like the thoroughness of the reporting, Caroline, that's coming through from the governance team. So please do feedback. I mean, I've thanked them directly at the time, but it's really good to see this coming through. Obviously, we talked about the invoicing issue, but we've had a more up-to-date conversation around that today. So I don't think there's anything sort of live, Priya, that I want to draw out from the written reports that you've got here, because the real life has overtaken it, I would say.
Thank you very much. And on that basis, I know a number of the boards sit on the audit committee as well. Are there any further comments or questions? Thank you. Let's move then to remuneration, and that's over to Tim. Thank you.
Thanks, Priya. Like audit, we've had two meetings, both quite close together, in this case in June, on the remuneration committee. As you can, again, I'll take the report as read. A lot of focus on the consultation and reorganisation, which we've talked about today as well. We've had conversations about that frequently over the last few weeks and months, and we are broadly assured about where we are, which was good, with some things that were showing as red here, but they've changed in time. So they've now gone from red and become assured as we've got further information. So that's very positive. We had an extensive conversation around a parliamentary and health service ombudsman query, which had had a lot of focus from the organisation, and we had a good strong debate around that, which was good. Fit and proper persons test, again, we had assurance on that. So there were some conversations around leadership pay framework, which are important and complex, but again, we've navigated that to, I think, the satisfaction of all members of the committee. Shall I move on and talk about the finance one, Priya, while I'm on? Yeah, which is skips over Sajad, I'm sure we'll come back on his committee in a moment. So we had a meeting back in May basically the end of the financial year. And the important news is, as I think Ollie touched on earlier in the finance report briefly, in fact, no, he maybe didn't actually, because he was talking about this financial year, but we closed the year successfully, which I think is a huge performance and credit to obviously everyone in the organisation, but I particularly like to thank on record the finance teams in both the legacy organisations and obviously now the new organisation, because a huge amount of work for them. And as Alone has already talked about from an audit perspective, that meant 2 annual reports and so forth. But the work that underpinned that was incredibly hard for them. So they've done a great job. And also the performance as well has been quite good. And I think against the backdrop of previous years, that's to be commended. Again, we've got to keep an eye on our SIPs would be the main message. I'm sure we'll talk about that in coming weeks and months as the cost improvement plans for the members of the public, which are a key part of our financial performance moving forward in the year we're now starting. So a lot to be done there. And Thames Valley Cancer Alliance is an area where a lot is ongoing, and I'll leave that to be talked about at a later date, I think.
Thank you very much, Tim. So in relation to remuneration and finance and performance, any comments or questions? Thank you again to committee members and exec leads for those. Commissioning and population health, over to you, Sajad.
Yeah, so as the board will know, this is a new board subcommittee that's been set up. We had our inaugural meeting on the hottest day of the year, I think, on the 24th of June. I'd envisioned it to be face to face, so it wasn't very popular with a number of attendees, but most people got there. And luckily, we had an air-conditioned office hosted by our colleagues at Windsor. So very good turnout, a lot of diversity in terms of different parts of the system, local authorities, academia, public health, on top of the normal kind of people you'd expect. So the goal is to get as much diversity into that, and to get as much, left field thinking. Just to assure the board, we went through a detailed assessment of our current reality, as the board would expect. As we move into strategic commissioning, there is a whole discipline, there is a whole framework of about 8 domains. I won't go into too much detail. The executive team has recommended that we start sprints in four domains, which cover 2 main areas. One is understanding our local reality. That's both the assessments of the population, but also our contractual baseline, but also developing our population health strategy in terms of priorities. So those sprints have been kicked off. Our watchwords at the committee is to be ambitious but realistic. As part of that ambition, we already are doing a lot of stuff, including the Innovation Fund. That Innovation Fund is roughly about 1%, just under 1% of our total budget. That puts us into probably the top 2 ICBs in the country, just by reference. Only 12 ICBs have a ring-fenced fund. We are one of those, and I think we're at the highest. But that is only the start of a multi-year journey. To be able to really deliver our strategic objectives that Caroline discussed earlier, we need to be very, very single-minded that this is a multi-year investment. It will require more than 1%. One ICB in particular, West and North London, have already targeted a 5% ambition in the next 3 years to get to 5% to spend on prevention and inequality. So I think it's something for us as a board to consider going forward, that we do need to grow the size of the pie. That can come through a number of different ways. We can discuss that in detail. But yes, we are starting from, a position where we are doing a lot of good things, but we do need to grow our organisational capabilities and muscle, in addition to delivering the new metrics that have been produced by the NHS oversight framework. So I'll stop there, Priya, and open up for any questions.
Thank you very much. I think you'll be commissioning for estates as well with the change in weather as well. So it's very much part of what will be our underpinning infrastructure to achieve good things for our population. Let me open it up to questions, comments. I think the feedback about centralising and having a broad membership for that committee has been very positive. To have that at the start is really important, and it's that building of trust is of major importance. And it comes back to what we were saying about the Lord Mann review and our anti-racism work. Trust and confidence is the underpinning to people being able to access good health and live full lives. So really important that we tie these things together. Good. I think I can't see any other hands, so thank you. We would normally now have any questions from the public. We don't have any for today, but I hope that the topics that we've covered are exactly those things that the public would have wanted to ask questions about, so that's good. May I ask then board members for any other business? And I am not seeing any hands. So thank you all very much. Thank you, particularly our thanks go again to the mental health in schools team from all of the board. That was a really superb way of showing what impact can be made. So thank you very much. And we are next meeting on the 16th of September. So see you then. Thank you.
Thanks, everybody.
Take care.
Thanks, everyone. Bye-bye.